anybody, those that are out there, can you see me live, or are we still not connecting? So let me know right now if you are seeing or hearing me, as I apologize for these technical difficulties. Sometimes technology can be a two-edged sword. And let's just see what's going on here. We are having challenges here. And all right. Well, you know what? We're going to do this real quickly here. Lord, I just pray that, God, you would just, so where are we at? Is anybody able to still see or hear me, or nothing yet? There's another link where 20 people are at. Let's just see what's going on here. As I would, where are you at right now? Can anybody see or hear me at this moment? According to my, where I'm at, it looks like I should be able to. All right, Mary, you saying you can see and hear me? All right. Well, listen, thank you for your patience. All right. Let's just start from the beginning here. I don't know what that was about. How many of you just love technology? How many of you just kind of say it is a beast or a two-edged sword? But regardless, let's get started, because I really have some exciting information to share tonight as we go deeper. Last week, we talked about skinny reasoning, and I brought in a urosepsis case study derived from my lens of current clinical practice. And it's short, concise, but in about 20 to 30 minutes, you can bring and practice the most important skill your students must master, which is clinical reasoning to make the correct judgments. And you know, our goal as educators is that we must provide opportunities to apply the learning. Your students can read the textbook. You don't need to regurgitate it back to them. They're adult learners. So the bottom line is, we talked about in the earlier Facebook Lives that again are available on my Facebook page, Keith RN, Think Like a Nurse. Got some great content in 30-minute segments of how you can practically decrease the infobesity, which many of us struggle with, including myself, again, identifying what's most important. Today, we're going to go deeper with a case study that a level that I've created called Unfolding Reasoning. Now, the skinny reasoning that I shared last week is about 4 pages long. It's two parts, 2 pages. You can do that in 20 to 30 minutes if your students come prepared. If you're using that level as a clinical replacement activity, it takes about 2 to 3 hours for a student to do individually. So the unfolding reasoning is the same topic, the same patient, but 8 to 10 pages in length, takes about 4 to 5 hours individually if you're going to use it for a clinical replacement activity, if some of you are still being held back. And so I want to let you know that, you know, my unique perspective that I bring to nursing education, I'm a newer educator. So if you're less than 3 years out there, you know what, full time, I can resonate with you. And I want you to know that you can make a difference because you bring that clinical salience. And I've been an educator for, again, less than several years when you combine my adjunct time, but more importantly, bring that lens of practice of 36 years into all that I do. And really, you know, what I do with Keith RN, I stumbled upon this as I just was invited by Linda Caputi back in 2012 to share some innovative strategies I developed from educating nurses, and had a breakout session at Elsevier's National Faculty Development Conference. And my website was very small, and I just made it my passion to create tools and resources for time-strapped educators so you can transform the way that you teach. But before I begin and diving into that unfolding reasoning and going through it, which we will, we have to talk about nursing education, and more importantly, nursing's dirty secret, because When we look at the problem of failure to rescue, this is a problem that's killing literally thousands, if not tens of thousands of patients every year. And it's because most of our students don't have the clinical judgment developed at a level that they are entering into practice safe. In fact, one study showed only 23% of graduate nurses who passed the NCLEX met entry-level expectations of clinical reasoning. And again, a patient doesn't just suddenly code, typically. Most have a 6 to 24-hour trend and of decline, of vital signs that are changing. And it's recognizing that relevant data that's going to make the difference, literally, between life and death for a patient. And so I think it's really important that as educators, we ask the why question ourselves. Why do we want to innovate our classrooms and make it active learning? Why do we want to develop the clinical judgment required for safe practice and licensure? Is it all about passing the NCLEX? Is it all about passing the upcoming next generation NCLEX? Or is there a greater why, which is that we want our students to practice and develop the clinical judgment required for safe practice so that patient outcomes are the best possible and we can begin to be a part as educators because we're emphasizing application and the usage of knowledge, that failure to rescue and failure to recognize can be something hopefully in our past, but it is a present problem and too many patients are dying. And so we must never lose sight as educators that it's all about the patient and helping our students see that are very ethnocentric or very self-centered themselves. It's all about me? No, it's all about the patient. So when we can bring in a patient-centered perspective using case studies and focus on how we can improve their outcomes, we can make a difference and save a life. And so, I want us to kind of remember that. And if there's one thing that we as educators must emphasize to help our students lay the foundation to be safe in practice, to recognize these key trends, this is my one pearl for tonight. If you remember nothing else but this one thing, CO equals SV times HR. That pathophysiologic formula is foundational to safe nursing practice. And if your students do not understand it, they will be unsafe in practice because, as you know, for those of you that feast on pathophysiology or who teach it, you know what that means. Cardiac output equals stroke volume times heart rate. And so this is the takeaway. What is the earliest compensatory response when a patient begins to have a volume depleted state? Let's say they are going into shock. They're bleeding internally. What's the earliest compensatory response? Well, when that formula is known and understood. Remember we talked about in our earlier sessions, understanding essential content is our goal. So therefore, let's make sure that our students understand this formula. But you know what? As educators, we must teach it. And we need to teach it well, and we need to teach it repeatedly, especially in our clinicals, so that that trend of an increasing heart rate, we're asking that question that every good educator does. Why? Why is the heart rate going up? Why is the blood pressure still relatively stable? Again, if it's the declining compensation, it's because of that formula understood. And we're going to situate, the reason I'm sharing this is that we're going to contextualize that formula in this case study, because what unfolding reasoning does that skinny reasoning doesn't, again with the same topic, is that it has higher complexity for your advanced students, because we need to prepare our advanced students so they transition successfully to real world practice. And the bottom line is that the unfolding reasoning has the initial scenario, but then a change of status that needs to be recognized. 3 hours later, the patient complains of this. This is your vital signs. This is your assessment. Now what do you do? I contextualize that with open-ended questions, no multiple choice or guess allowed. So let's have some fun, and we'll get into this in just a moment. But when you look at, I'm going to share my screen so we can jump right in and kind of just make sure technology plays nice with me here. So I'm going to share, and I'm going to go off the screen for just about 10 minutes or so as we work through this case study. I'm going to make my get this going here, and we will present the rest of our case study. That this is actually the same case topic, and this is Jean Kelly. And remember from last week, if you were here, she is an 82-year-old woman who's been feeling more fatigued the last 3 days and has had a fever the last 24 hours. She reports a painful burning sensation when she urinates and frequency of urination the last week. Her daughter became concerned, brought her to the ED when she did not know what day it was. She's mentally alert with no history of confusion. While taking her bath, she was weak and unable to get out of the tub and used her personal life alert button to call for medical assistance. Now, all of my case studies, and this is a practice question, have the same opening questions that Tanner's model of clinical judgment asks. What clinical data do you notice that is clinically significant, and what does it mean? So we're asking those questions. What are you noticing that's abnormal here? That frequency, burning of urination, fatigue, weakness, all of those things should be red flags. The fact that she's 82 years old, again, a red flag. Here's her social history. And I'm going to jump into I'm going to highlight what's different with unfolding reasoning. So what I want you to do is kind of get a sense of some comparison and some contrasting. So you can kind of get a sense, as an educator, what case study would best serve your needs as an educator. So this information is new. I identify her past medical history and her 8 home medications. Then I have my students, they have their student version of this case study that's totally open-ended. It's a writable PDF document. And they have to connect with literally just writing in the lines, diabetes type 2, what medications are treating that. They're beginning to form some very basic pattern recognition, connecting those dots. Hyperlipidemia, let's draw a line from hyperlipidemia to which one of those numbers? Hypertension and gout. Then they need to get their drug handbook out and ask themselves, what pharm class are these common medications? Again, my goal is not to do the obscure meds that are out there, but the most common. What's the pharm class and the expected outcome for each of these medications? Then we begin this is a pathophysiology question that's also new for the unfolding reasoning. One disease process often influences the development of other illnesses. We know that as practitioners in the clinical setting. And so based on your knowledge of patho, which disease likely developed first, then initiated a domino effect in Jean's life? So here you've got these problems, diabetes type 2, hyperlipidemia, hypertension, and gout. Which one started the cascade of dominoes of other problems? And if we know our patho, we know that the diabetes is no friend of most patients. If it's not well controlled, it can lead to hyperlipidemia and then lead to hypertension. And again, a very simple question, but what we're doing with our students is that we're helping them connect the dots with past medical history. That when we look at some patients who have like 6, 8, 10 problems or more, there's a relationship typically with most of them. Usually diabetes, type 1 or type 2. And again, helping our students, again, visualizing the pattern recognition. That's our goal by bringing clinical salient case studies into our classroom. We want to literally have that low fidelity simulation experience where they are practicing the reasoning, the thinking, just as if they were getting this information or caring for the patient in the clinical setting. So now we have a set of vital signs. And again, we look at our temperature. Our pulse rate is 92, our rate of 20, BP 102/74, O2 set of 96. We can see our orthostatics. We can see that they're positive. So all of this initial information is the same as skinny reasoning. We'll look at our head-to-toe nursing assessment. And again, I'm not going to review and read all of this, but what I want you to look at and see is that, looking at, for example, the voiding, the urine is clear but dark amber. We look at some of the breath sounds are clear. Overall, there's not a lot of problems there that are present at this time. We do a chest x-ray, and that looks basically that's ruling out the cause of infection. We look at our chemistries, and we begin to see that, again, trending our clinical data, looking at our sodium, potassium, glucose, creat, seeing where our differences and seeing where the trends are going. We can see some of the problems. And again, clinical reasoning in its bare essence is if your students can do two things, or more, but the two I want to highlight are, can they recognize the priority or what's most important to focus on in the chart? And can they recognize the significance of clinical trends? In essence, what direction, when you compare the most recent to the current, what direction are their vital signs, assessment, lab values going? So in this context, we're just looking at the trajectory of our labs. And again, creat is always relevant. Look at where our creat's going. Look at our white count, slightly elevated, but not grossly abnormal yet. We have a UA, and we can see the prior and the most recent, but we can see that, our white count micro is way too many compared to the most recent. Large amount of bacteria. This is a classic UTI urinalysis. And again, look at our magnesium and lactate. Our magnesium is okay, but look at our lactate at 3.2. Do your students understand what a lactate is representing? And again, they need to know their patho. They need to recognize that anaerobic metabolism due to a poor perfusion state, as you know, creates lactic acid. And that's where your lactate is coming from. So again, we can go a little deeper. This is an exercise I created called lab planning. And what it does, I pick out in the case study a couple of the labs that I think are really, really important to go deeper on. Lactate is a classic example. Whenever you have a lactate in the chart, whether it's positive or whether it's normal or abnormal, lactate is always relevant because what it's telling us about the perfusion of our patient. So again, I want my students to get out their lab books, look at the lactate. What is it? Normal, red flag, critical. What's its clinical significance? This is physiologic significance. But then I ask this really important question. What are the nursing assessments and interventions required if you have a lactate that's high? What does the nurse need to do with that information? Most of your students can say, this is a red flag, this is an abnormal lactate. But the next step of clinical reasoning, the next step of nurse thinking is to then, and this comes with experience. So I'm drawn upon my lens of decades of clinical experience with this. But again, we then need to make that distinction. What do I do with my lactate being that high? What am I going to be watching for? This patient's at a risk for sepsis, going into septic shock. So I need to watch my blood pressure, my heart rate, my respiratory rate, all of the above, literally every vital sign, very carefully as a result of this abnormal lab. And so again, we can create a plan of care with an abnormal lab. And this is just a very simple exercise and activity, but it's unique to my case studies because I've created, through my lens of practice, this emphasis of lab planning. And so then we ask some very important reasoning questions, and it's the same in every case study. So whether you do an unfolding reasoning of this sepsis case study or on cirrhosis or COPD, the structure of my case studies are all the same for the same level. So with this one, what's the primary problem that your patient is presenting with? And now I want my students to recognize this. Does this patient have more than a UTI? Yes, they've got a positive UA. Yes, they've got some softening blood pressure, but their lactate is 3.2. They're sliding into sepsis. This patient is basically in urosepsis, or their lactate would be normal. So we want to help our students, and this is where we ask the open-ended question in our classrooms. What do you think is the primary problem? And talk about it. Reason with your students. Be that guide on the side. See, this is where you're not spoon feeding. You're not giving them the answers. You're having dialogue, discussion, and you're fleshing this out, and you are kind of playing the devil's advocate, and you're kind of just, if they're going down the bunny trail, you hop along with them and see how far they go before they recognize, maybe I made a mistake in this assumption, and then they can learn from their mistakes, grow from it, and be the better nurse because you're practicing the clinical reasoning. And again, if you're just relying on your clinical experiences, which are almost non-existent the last few months, or on on your high fidelity sim, that's not happening, and most students don't get enough of it. So now we ask them, what's the underlying cause or pathophysiology of this problem? Let's talk about sepsis. Let's talk about SIRS. Let's go a little deeper and see what your students understand about the pathophys. And now got the errors or the orders of what the doctor in the ER ordered. They ordered their IV, their saline, the Tylenol, ceftriaxone after cultures, morphine, small dose 1 to 2 milligrams every 2 hours. What's the rationale and the expected outcome for each of those orders? But then I ask a different question for the unfolding reasoning. This is an NCLEX question, and it's also a practice question. What do you do first? You got 6 orders here. IV, saline, Tylenol, antibiotic, morphine for pain. They're all good orders. But as a nurse, if you've got 6 orders, and in this case 5 orders, what do you do first? Situate the ABCs. Airway, breathing, circulation. I don't see an A or a B order, but I do see a C with circulation, with that bolus, getting my IV established, and then my bolus. Those are the 1-2 punch. Talk about it. This is a great discussion when you can talk about the order setting and why you chose those orders. This is where small group work, you can make this a 5 or 10 minute small group activity. Again, innovating your classroom, getting them active, getting them engaged, not just spoon feeding. They are feeding themselves with relevant dialogue with their student colleagues. Then I've got a dosage calc question. This is also new to unfolding reasoning. Looking at the 1 gram of ceftriaxone, it's in 50 mLs. How quickly do you give it? And then what does that mean? What do you set your pump for? And the nursing assessment consideration. So again, doing some very basic but important, we're practicing. Can you see how this is very similar to a high fidelity simulation? You just don't have the IV pump in front of you, but you're doing all the other thinking. Third question, what's the nursing priority and what interventions will you initiate based on that priority? And then we go on, so that's basic nursing process. Now we're going to go deeper though. These are new questions that are not in skinny reasoning. What body system will you most thoroughly assess based on the primary or priority concern? So again, we're going to talk about, we're going to teach our students to do focused assessment, not a mandatory 20-minute head to toe and obsessing over vowel sounds. We're going to know. We're going to bring a practice-based perspective of what does the primary body system. We got urosepsis. It's basically, it's going to be, circulatory as well as urinary and respiratory. Watching that respiratory rate, that's an early predicator of a decline if it starts going up. So again, talk about the body system. What's the worst possible, most likely complication to anticipate? And again, that's basically going to be septic shock, is it not? I'm going to let this go. My little counter is just kind of going crazy here. What assessments will identify sepsis early? You see, this is the key where we're killing patients in practice as nurses because we fail to recognize the significance of a trend of an elevated heart rate. And this is where nurses who don't understand that CO equals SV times HR, they don't understand that. When they see a trend go from 80 to 100, 110 in a 4-hour time frame from one set of vitals to the next, they just blow it off. They don't really recognize its significance. So again, early recognition. So these are problem recognition priorities. What interventions will you initiate if this complication of septic shock develops? Let's say the bottom begins to fall out. Then talk about the psychosocial needs and what that looks like in this context. But now we have a completely new unfolding scenario. We have to evaluate 2 hours later the response of this patient to your intervention. So this is only 2 hours later. Your physician orders have been implemented under medical management, and this is your new set of vital signs. And so if you look at that set of vital signs, the temp is 101.4. Let's compare it to the most recent, 101.8, about the same. But look at our heart rate. It's gone from 110 to 126. Is that a concern? What could that mean? I believe it's a compensatory response to a volume depleted state. She's probably sliding into sepsis. Her respiratory rate is about the same, but look at her blood pressure, and let's teach our students, not just our critical care advanced students, about the importance of mean arterial pressure, or MAP. 65 or greater is the minimum for perfusion of our body organs. Well, her most recent was very marginal, 102/50, MAP of 67. Now she's 92/44, MAP of 62. That's a problem. So if we are teaching and contextualizing our content to sepsis, perfusion, we can begin improving the practice readiness by practicing this thinking every time you have class. Get a vision for that, because you can do it. And so again, her head to toe assessment, look at her cardiac status. Her skin is warm and dry centrally, but she's becoming mottled in appearance and cool to touch in the extremities. Again, if your students understand shock, they know that that's not okay. That's that shunting. You see, when your students understand their pathophys, they understand the why. And so again, now we have to evaluate just like we do in practice. Has the status improved or not as expected to this point? Is this patient getting better or worse? You know what? I just provide the data in the case study. I also include a fully developed answer key for faculty because I know that we all like that security. I know I like it as well. So I do that for every case that I've written. Does your nursing priority or plan of care need to be modified in any way after this evaluation assessment? Based on your current eval, what are your nursing priorities and plan of care? Do we need to call somebody? Do we have a problem blinking at us? Again, the nurse is just this, the nurse and the patient. No one is looking over her shoulder or his shoulder. We are needing to teach problem recognition. And again, let your students figure this out. This is where they can have that small group work and discuss it amongst themselves and have each of yours, break them up into small groups, 3 to 5 students. You take question 1, 2, and 3 and let them decide. And then you facilitate. You don't spoon feed that discussion. Now I put in my unfolding reasonings an SBAR framework. So the bottom line is your students can practice giving a concise SBAR to the primary care provider. How many of you know that SBAR needs to be practiced, just like clinical reasoning, to do it well? So let's practice it in our classrooms. Let's just have them concisely write this out and then have one of the groups share it, or have them each take an S, a B, an A, and an R, the 4 groups. And again, have fun with it. Give them accountability. Get them active. And deep down, your students will appreciate that. So again, you as an astute nurse recommend that this patient is volume depleted. You get new orders for a saline bolus and a catheter to watch the urine output. And now 1 hour later, you've given the bolus. How did the patient respond? Well, let's look at our heart rate. Our temperature is going down slightly. That's a good trend. Our pulse went from 116 to 92. Again, when your students understand that patho formula, that's why I shared it in the beginning, you're contextualizing what students will see in clinical practice if they're volume depleted or they're becoming normal volume and that restoration is taking place. The rate has gone down. The MAP has come up. The blood pressure's come up. The GU, she's got 200 mLs of cloudy urine in the bag. And again, if she's got a UTI, we expect cloudy urine. So it's an abnormal finding, but it's expected. And then we ask evaluation questions. Has the status improved? And what data supports this evaluation assessment? So again, let your small groups figure it out. And again, make it active. And all of this unfolding is not in skinny. As you can see, this is a higher level of complexity. But again, your advanced students need this complexity to practice the realities of real-world practice in the safety of your classroom. So then I kind of like to do a second SBAR. Don't do it with every case study. But again, they have to give report to the nurse because they don't stay on the shift for 24 hours. They're on the shift for 8 or 12. Let's give that report. And then we basically then look ahead to discharge, education. A nurse is an educator, and they never lose sight of that. So I always include discharge and education priorities when she does go home, and what are some practical ways to assess the effectiveness of your teachings. Let's talk about what would we teach Jean. She's living independently. That was her standard. And again, we can just bring in some very powerful and practical teaching. And then because this really is in essence a simulation, it's just not high fidelity sim, reflect and debrief. What did you learn? What did you do well? Let's just talk about this as a class in your small groups. What weaknesses did you identify? And most importantly, how will you apply what you learned caring for future patients? Again, that's our goal. Every case study, every active learning activity, regardless of what you're doing, always bring it back to the bedside. How will you apply what you learned in today's class to the next patient you care for in the clinical setting? Because that's what it's about. Nursing education and nursing and that kind of, it's always about the patient. And so let's bring, again, the patient-centered perspective into what we do. And so I'm going to stop sharing. I hope you're still with me. I hope I didn't lose anybody. I'll just kind of go back to my main screen here, and we'll put this back together, and I'll get myself back, and we'll finish this up and look forward to the questions that you may have as we move forward from here. So let me just go back, and I should be, tell me if I'm basically back where I should be, and I do believe I am. So I am going to keep going here. And just want to let you know that, if you go to keithrn.com, I've got a free case study for you on COVID-19. It's my skinny reasoning case study. It's a great respiratory exemplar, as you all know, but I also have the unfolding reasoning on my website, KeithRN, for about $25. And I've got about 30 topics on my KeithRN website, but my best value is in the membership. And I've got an all-inclusive membership that has over 110 case studies. I've been busy the last several years, and I've also collaborated with some faculty experts out there that have really been a blessing. And so I can't do the specialties like peds, OB, and mental health. No, give me a good med surg and I can write those. But the bottom line is that, go to thinklikeanurse.co, and that has all the information to see what my topics are. You can explore that. And if you're a departmental leader, or if you'd like a departmental membership, just email me at keith@keithrn.com, and I can get at least a 50 to 60% discount for your department to get all faculty on board, and clinical adjuncts are no additional cost. And so I really have a faculty-centric model to make it affordable and get your faculty all on the same page. And so in closing, as you know, and as I've learned the hard way, you can't do change alone. The things that I'm calling you to in nursing education through the things I've shared, we're kind of going against the stream here. If you didn't notice that, what culture and academic culture can sometimes resist change. You can't do it alone. You need a band of brothers and sisters around you. And that's why it's a pleasure for me to come alongside you on Thursday evenings or watching the repeat, as well as my Facebook group for nurse educators called Teachers Transforming nursing education. I'm not a huge social media person, but I love this Facebook group because you've got over 5,000 educators from the United States, Canada, and other countries of the world, which is amazing, sharing their challenges and getting instant and real quick responses to your problems or challenges you're facing. So I want to encourage you, go to that Facebook page if you're not already a member. Again, it's a closed group. I don't want students and everybody and their neighbor there. I want educators. And so let me know you're an educator. Answer my questions, please, and I'll get you inside. So the bottom line is that when we look at active learning, remember, it's all about preparing our students for practice. And if we emphasize the reasoning with the case-based approach, you know that next generation NCLEX, it's unfolding case studies. And it uses the essence of Tanner's model of clinical judgment, which these case studies do as well. And so I just want you to recognize that, my students didn't love active learning. They resisted. But they're adult learners. And by the second or third session, they saw the value, that it was relevant. They recognize relevant. You're adult learners. They recognize hoops as well. We want to make it relevant and meaningful. And I got buy-in, but I had to persevere. And so I know your students are not, my students in Minnesota are not unlike yours wherever you're from. But I want to encourage you that you can make a difference. You can improve practice readiness. And I just would like to know, just kind of as you look at some of the, the challenges you're facing, what questions do you have as you look at this unfolding case study? I want you to reflect. Look at your case studies you're currently using. If they're not Keith RN cases, I'm not saying I've got the best in the world. No. But I make it my goal to replicate clinical realities, just like a nurse experiences them, open-ended and a step at a time. That's why no multiple choice. That's not an option in practice. Let's make sure our case studies and our active learning, whatever it is, whether it's the ones that you're writing as well, which is awesome, make sure they are closely replicating your clinical realities. And so let me know what questions you've got. I want to thank you for spending a few extra minutes. I went a little, had about 7 or 8 minutes before you even got online today. So thank you for persevering with me tonight. I was hoping I wouldn't have to shut shop and not even get a chance to share what I had on my heart tonight. So I want to thank you for coming. And I just want to I'll back up in the chat here. I'll basically just go over some things here that I see from questions. And again, my goal is just to serve your needs here. And so stay with me for a few and we'll get some good information. And I want to just give a shout out to Mary Ellen, who says, I teach CO equals SV times HR, and every time it's like a new concept in my patho assessment and pharm classes. This is a really important principle, Mary Ellen, and I want to thank you for sharing, because some of us as educators make this fatal mistake. Well, they already covered that in pathophys, or they already covered that in the last semester. You don't reteach, but you must emphasize and repeat what's most important, or it gets lost. Because you know what? Our students are getting lost in the trees of infobesity. The forest is way too steep. What's most important, so Mary Ellen, I want to commend you for what you're doing with that. And so thank you so much. And so, this is Feriden says, we don't learn much about MAP in school. Well, you know what? Whenever you do those Dynamaps, for the electronic blood pressure, it gives you the systolic, diastolic, and that third set of numbers, that's your MAP. Keep an eye. Make sure it's a greater than 65, always. So thank you. And you know what? We should be teaching our students about mean arterial pressure. That's a basic perfusion principle and concept. So if we're in those concept-based curriculums, let's make sure that we're highlighting, because I think that I think we're talking about it, but let's at least be intentional to bring that context. And I think this is why a good case study can bring context to your content. And that's a transformational paradigm shift that Dr. Pat Benner advocated for in educating nurses, a call for radical transformation back in 2010. And so Chelsea asked this question, and I'll put that out there. It says, would you recommend, let me just make sure that shows up here. Okay. Would you recommend skinny or unfolding reasoning in a first semester fundamentals class? Chelsea, I would go, don't give them a fire hose. You're going to scare them from nursing profession with that because that's a very complex case study. I went through it pretty quickly, but it would take you a good hour to do that well in a classroom as a faculty guided discussion. That's too much. Go short and sweet with the skinny reasoning. That's really going to serve your first semester students well, as well as your first semester practical students. And so, yes, that's really a great case. But you know what you can do, Chelsea? If there's things you liked in the unfolding reasoning, like the priority setting, you can pull those principles out. I just wouldn't do the whole thing. I would keep it as short and sweet. That's why I'd go skinny reasoning. Let me ask this question from Patricia. If teaching oncology topics, solid tumors, for example, how would you approach that? And so again, Patricia, think about oncology. There's always a specific patient and there's a specific problem. And as you know, what's one of the most common problems in chemo patients is sepsis, neutropenic fever, and sliding into sepsis. So again, think about scenarios that are most common to oncology and then contextualize it. This is where you can write your own scenarios. And I've got some oncology case study topics as well with breast cancer that are also available on my website or membership. So that would be that's kind of, so I wouldn't get focused on the different types of cancers because there's 101 different cancers, but what's the problems that are universal to oncology that we can teach and bring that in? And so, yeah, Wendy's got a great question. I just want to get to. Thoughts on group work for students when social distancing or meeting remotely. The thing that you can do, Wendy, is that, if you're doing like Canvas or other Blackboard discussion board, where you're meeting online, you have the ability, I'm not a Canvas ninja, but you can basically create small groups with your classrooms for some small group discussion work. It doesn't have to be a complete synchronous discussion of 30 or 40 students in your class. You can break them up online. And that's where I would get in touch with your tech support people in your program and basically make that happen. And that would be my best response to that question. And so Patricia answered that, Wendy, better than I did, I think. So thank you for sharing that about with Zoom and what that looks like. And I'm just going to keep going through my comments till I hit the end here. And Chelsea asked this. I used this case study last spring during COVID over Zoom. Students worked through the first pages and we discussed over Zoom. Excellent, Chelsea. And again, this is where you as an educator, because you have the PDF document, you can post this case study ahead of time for your classroom, whether it's online or whether it is in the traditional setting. Let your students come to class prepared, having done the first 1 or 2 pages. Get them started, get them immersed, get them engaged, and now you're just going to facilitate the rest of the discussion. So I love that, Chelsea. Thank you so much for sharing that. And you're very welcome, Farrah. I'm glad you're liking this. I think you're a student, but I'm glad you're here. Let's see here. I've got Wendy answered that one, and so I'm just going to keep going here with Dee Feidler. I teach at the I'll put you on the screen here. I teach at the beginning of the program and at the end of the program. What suggestions do you have for the new nursing student case studies? And so again, what's unique to the cases that I've developed is that they have different levels of complexity, Dee. So, for those first semester students, that skinny reasoning is short, concise, basic reasoning, basic priority setting, and nursing process. Just what your newbies need. You don't need to overwhelm them. Plus, you're helping to apply and contextualize pathophys and F&E with your lab values. Again, most students are coming into that if your curriculum is structured as such. So you're helping them basically contextualize that essential content. Then by the time they get to the end, you use the same topic. And what's kind of cool is that it's the same scenario. They would have remembered it like 2 years ago, the basics, but now you're going deeper. Now there's that priority setting. Now there's more complexity of problem recognition. Now there's the unfolding change of status. So we're building, and really what these cases do in a curricular language, they're scaffolding, just like you do in your curriculum, simple to complex. The case studies quite concisely do the skinny as the simple and the complex with the unfolding. So I hope that was helpful. And again, if any of you have questions that I didn't answer or answer well enough, email me at Keith, Keith, at keithrn.com. And so, yes, Mary Ellen, you're so welcome. It's my pleasure to support the needs of educators and, again, just share practical principles from the literature, my own practice lens, and helping you to rock it in the context. And so, Patricia, you are just being a real helper out there. I appreciate that so much. So thank you for that. And talking about a map, Mary Ellen says, yes, they do get map in fundamentals. So bottom line is, if they didn't remember it, maybe it got lost in the forest of TMI. But again, recognize that. So thank you for sharing that. And that's why we need to, again, this is why, when we are teaching too much information, they lose what's most important. They forget what's most important. So again, this is why we as educators must recognize that too much is the enemy of the best. Let's focus on what's most important. So excellent. And Patricia says, yes, I go over neutropenic fever, sepsis. And Patricia, if you're doing that, that's 90%. Maybe it's not that high, but that's the majority of a lot of the problems we see in our oncology population in the acute care setting. So thank you for sharing for that. This is a question I want to answer here, and this is Chris. Chris, great to have you tonight. He says, do you find any critical thinking or decision-making skills are improved by students learning nursing diagnosis statements? Chris, are you trying to push my button? Because I struggle. A NANDA statement, unless it fits, like a fluid volume deficit did in that last case study. You know what? The literature is actually, Dorothy Del Bueno, Delbueno, has done some incredible work on this topic of nursing diagnostic statements and problem recognition. It's an impediment. It actually is part of the problem. Students don't think like a nurse. We've got to give them the flexibility. Because you know what, Chris? If you're a nurse in practice, you don't think in three-part NANDA statements. You see the essence of the problem. Fluid, we just see, low blood pressure, blah, 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 and we capture the essence of the problem. NANDA doesn't do it for most problems that are a change of status. They're great for stable patients with good outcomes, but I would go NANDA light, because NANDA light, have a brewski of NANDA light and hold it loosely. But don't throw the baby out with the bathwater. But again, let's not hold on to it like a death grip either. So thank you for bringing that up. And yes, Mary Ellen, you're very welcome. And you know what? I think we have gotten through it. I have no further questions. So you know what? This has been a fun session. I want to thank you for coming tonight. And you know what? We'll be back next Thursday at 8 o'clock. And, if you didn't catch it in my initial intro, I did pass my comprehensive exam. So you know what? I'm one step away. I've got to do my dissertation defense. Once that is done, I've got a month of studies, and you can call me Keith. And I'm excited to have that PhD and the growth that I've experienced. I'm almost completed my journey, and my burden is much lighter. And I want to thank you all for sharing this journey with me. Blessings to you all, and we'll see you next week. Have a good week.